So first of all, I want to give a quick shout out to the rest of the team that's worked with me to help put the webinar together. So our technology chair, Paul Wampler, if anything goes wrong technology-wise, it's my fault, but he will fix it. Thank you, Paul. And Sabrina Camazoli and Jamie Gordon for helping put the panel together. You know, when I'm working on my own, it's a good day when I can get one doctor to see me on time. Getting 5 docs to all in the same place, especially ones that are in high demand, is a real trick. So thank you, Sabrina and Jamie, for you know, for pulling everyone together. To answer the most frequently asked question, attendees cannot be seen or heard. That's not a bug, that's a feature. So we're on a Zoom webinar. You can't see yourselves. So for anyone who took your first shower of the month and got all ready for the webinar, sorry, but we can't see you. So that's how it's supposed to work. And the second most frequently asked question is the session going to be recorded? And the answer is yes, it is going to be recorded if I press the right button. So if you're wondering whether you can get off early and still hear the rest, the answer is yes. Looks like we've got about 65 folks and counting, so that feels like a quorum, and want to get rolling. So if you have any questions, please submit them using the Q&A button at the bottom. There's also like a side chat thing, which is mostly just for kind of snarky side comments, but if you want your question answered, please submit it on Q&A. So this is a great treat to have the panel together. You know, this is not the armchair reflections of retirees here. We have 5 great medical professionals who are all at the peak of their powers and are working in the crucible of what will probably be remembered as one of the great medical and social challenges of our time. So I'm really delighted to hear from them, and thank you all for being here. We really appreciate it. What I'm going to do is ask each of you to take 5 minutes to just introduce yourselves and tell a little bit about how you got into the pandemic management business. And then we'll go around and do some audience Q&A. So without further ado, Dr. Garfein, the floor is yours.
Thanks very much. I am a plastic surgeon in the Bronx. I work at a large quaternary inner city hospital called Montefiore, and we're sort of the major academic medical center for a borough of 2 million people. My COVID story, both professionally and personally, are intertwined a little bit. I was at a conference on March 11th, and I got a phone call from my wife who works at 60 Minutes, and she said, hey, you know, 2 people who work here just tested positive for COVID, and I was in a meeting with both of them last week, and I suppose I should be now self-quarantined for 14 days. And so I sort of thought, wow, this is a real inconvenience, mostly because we were going on vacation at the end of the week. And I was like, oh, wow, you know, this is going to be a drag. And at the time, March 11th, things were just starting to heat up. Things were obviously very hot in Italy, but in New York, things were fairly quiet. And so we went into quarantine as a family, and we have 2 little kids, and we were at home in our apartment for the next sort of like 10, 11 days. And we were all tested and everyone was negative. About 10 days later, I went back to work, and work at that time, now we were sort of really in the throes of it in New York City, and lots of patients were coming in, and you know, parts of the hospital that were meant for conferences and meals were turned into ICUs, and the ER was rerouted, and all these sort of structural and procedural changes were happening. And I started working in the ER because they needed additional doctors to screen patients who came in with COVID symptoms. At the end of that week, my wife and our 2 boys said, look, you know, if you're going to be coming back and forth to the hospital, maybe we should get out of Dodge for a little bit. And they came to my mother-in-law's house out on Long Island. and that was sort of the last week in March. The following Monday, sort of the last Monday in March, one of my mentors and colleagues, a guy named Jim Goodrich, who was a world-renowned neurosurgeon. He was the neurosurgeon who separated the conjoined twins that we worked on a couple of years ago, and was an unbelievable guy, a Marine, collector of antique books, a polymath, just a super guy. On that Monday, he died of COVID. The next morning I woke up and I thought, well, this must be, psychosomatic at its core, but I really didn't feel well and went to the hospital and sure enough tested positive that day. So, I went through a 2-week period at home by myself, which we can talk about. That was one of the most sort of interesting journeys I've had, certainly as a doctor, but also as a patient. I think the isolation, I know we're probably going to touch on the isolation part in this panel, but being sick and being alone was something that sort of changed me fundamentally as a doctor and as an individual. Obviously, I never needed to be hospitalized. I got better, went back to work in one of our ICUs, and then just saw sort of COVID at its most vicious, and what you've heard in different parts of the country about this virus, when it's bad, is true. And Raphael, I'm sure you can add a lot of color to this, but people were just dying left and right, and we weren't doing very much to alter that. But things are, now getting better, and in New York, numbers are slowing down. We're down to about 500 COVID positive patients in our hospital. We've disbanded or dismantled some of the temporary ICUs, and we're not back to normal by any stretch, but we're a lot closer than we were 2 or 3 weeks ago. So that's been it for me. It's a great honor to be on this panel, and I want to thank you guys for the invitation.
Super. Thank you, Evan. Thank you. Mindy, you're up next.
Again, thank you so much for the opportunity. It's great to see my friends and colleagues and to share a little bit. I'm in Baltimore, Maryland. I'm a hospitalist, and my part of the COVID response was to help set up our convention center to be a field hospital. And we did talk with some of the folks up at Javits, and we tried to, and also internationally, we looked at some of the data and stories we could see from Italy and China. And so we set our convention center site to be for COVID convalescing patients, to try to be a place where hospitals could discharge patients that were closer to being stable and make room for the sicker patients in the hospitals. And so that's what we've done. They brought in a hospital architect and made an entire exhibit hall negative pressure. So we're like one giant COVID unit that's negative pressure, and we don our PPE and go in there and take care of patients. And we're for the state. So it was a very interesting setup where our directors are folks that are, Dr. Ficky is a orthopedic surgeon with military experience who set up trauma hospitals in Iraq, and Dr. Callahan also has a military background. And so it was a joint operation between Johns Hopkins and the University of Maryland to come together and do the state facility. And I think it helped very much to have people that just wanted to come in and build something that would be functional and be able to change and pivot to what the state might need. We weren't totally sure, but we tried to stay flexible so that each week we could safely take care of patients at that site, recognizing we're not a full hospital with all of the equipment that the hospitals around us had, but that we could safely watch over patients there. And I have a couple of pictures that were taken just to give you all an idea, but it's been an amazing experience to try to pull something together in about 3 weeks. there it is. So it just gives you an idea. It's pretty low tech, not fancy, but that whole area is negative pressure. So for the non-medical people on the call, it just, helps to reduce the COVID, the virus in the air. And then you can see, this is before we went live, we were training. And then I guess you could show the next picture. I think I just have like 3 pictures. That's sort of, if you're a patient, it's a field hospital. We have beds and recliners. And then that's me before I chopped off all my hair, getting some training.
Okay, great. Thank you. Thank you very much, Mindy. Rafi, your turn.
Okay. Hi, everyone. And again, thanks for inviting me to share some experiences. I'm out in Los Angeles at UCLA Medical Center. Probably the last place I ever thought I would end up when I was at Princeton. I'm a Northeasterner through and through otherwise. But on my sort of daily job routine before COVID happened, I'm largely a clinical researcher. I do HIV prevention research. My original training is in internal medicine and infectious diseases. Did clinical infectious diseases for a while and then sort of reinvented myself as a clinical investigator. And I do a lot of HIV and infectious disease care and treatment, and then a lot of HIV prevention research. And then as COVID started to arrive, our division chief is this phenomenal woman named Judy Courier, who also trained in Boston and then moved out to the West Coast years ago, said to all of us, a lot of us who are sort of researchers or other activities on a daily basis, basically it's all hands on deck. You're all clinicians for the foreseeable future. Everything that you're going to be doing, sorry, that's my Great Dane. He's excited. You're going to be doing COVID work. And that's what we've sort of been doing. We've been doing a lot of inpatient and outpatient COVID work. And in terms of what I've been focusing on, in addition to working on the inpatient wards here in LA, and I will say compared to certainly what Evan is experiencing in New York and others on the East Coast are experiencing, we never got to the point of system breakdown and overload. And no one really knows why that is. Certainly LA has the largest number of cases in California, and we're kind of still at the peak of it right now. Maybe it's because, the governor made a stay-at-home order very, very early on. Maybe it's because just the geography of LA is so spread out that there's intrinsic social distancing. So we never got to that sort of crazy level of resource triaging that other places had to do. But I started sort of being a COVID trialist, which I sort of never sort of thought I would be doing, certainly not more than 6 weeks ago. And all of a sudden we're testing new therapeutics because, of course, until very recently, there was nothing proven to work for treatment or prevention of COVID. A lot of hypotheses, a lot of rumor, innuendo, rumors flying around the internet. This does work, it doesn't work. Drugs that are active for other things being repurposed, anecdotal data, sort of turning information and science on its ear, and people really believing anything they could grasp because it was such a terrifying and desperate time, and people wanted something to do that might have a benefit. And it's really been a fascinating experience, because I don't know of any other time in history when there's been so much international collaboration about research information sharing, and the rapidity with which information is being disseminated across the internet and shared even before it gets reviewed in a standard peer review way has been both exciting and terrifying, because the level of evidence that gets out there and that people grasp onto is not our usual level of rigor, and people are doing things that really aren't proven. And it becomes a really sort of frightening context in which to take care of patients. So right now I'm involved in a lot of the treatment trials. We're getting into prevention. something I know we'll be talking about later because Kari's already sort of dared me to talk about this, is the data that just came out today about the first patients in the US treated with the new Moderna vaccine in their phase 1 trials. So, lots of exciting and hopefully promising things coming down the pike. But there's just an enormous amount of information out there, good, bad, and indifferent. And one of the biggest challenges is figuring out what to use and translate into the clinic and use therapeutically and what to believe. I'll stop there. Thanks again for the opportunity to share.
Great, great. Well, we look forward to hearing a lot more from all of you. Sara, you're next, and just let me know when you want me to put up your slides.
Sorry, everyone, I'm a slide person. I will go through them quickly, though. So please, right now. Yeah.
Okay.
So, oh, is it up? Yeah. So I work in a city called Alexandria, Virginia, that is directly across the river from Washington, D.C. And I've served for many years as a medical director of what's called the Antenatal Testing Center. I am an OBGYN, and then I have a subspecialty in taking care of high-risk pregnancy. I am purely a clinician. I do not do research. I'm not an administrator. So I'm at kind of the bedside all day, every day that I'm working. So next slide. Oh, do I do the next slide? Oh, there, okay. So I have had the benefit of working in a hospital system, the Inova health system, that is financially sound, and we've had the benefit of observing what you've gone through, Evan, in New York. And so we have been prepared with PPE and testing. Our first cases came in early March in our non-pregnant population, and my hospital was quickly at capacity. So you're at a much larger scale, Evan. We're only a little bit over 200 beds, but we were at 80 or 90 COVIDs in our 238 bed hospital with 30, 40 on vents. Our delivery is about 3,800 a year, and slowly we started to see the pregnant patients come in. So we saw some scattered examples of symptomatic pregnant patients, and then we had a serious respiratory distress patient in about, it wasn't until the 3rd week of April. And what I'd like to point out is pregnant women, by definition, even though they're very worried about getting COVID, they're young and they're female. So they're two demographics that actually don't have any particular risk factors. So they tend to do pretty well. Right now, we're routinely screening all pregnant women who present to deliver. We're finding that 9% of our population is COVID-19 positive. They're almost always asymptomatic, and that's a little bit less than what's seen in a place like where Evan is in New York. I'm routinely seeing 3 of these, maybe 4, maybe 2 a day that are asymptomatic COVIDs that I may be seeing for another reason, like hypertension or something like that. Next slide. So there was this initial speculation that pregnant women could be affected more severely than the general population because influenza is actually very, very hard on pregnant women. That's not been borne out in real life in our country or others. Women that are pregnant are not at an increased risk for catching COVID, or if they get it, developing worse symptoms. However, if they have other comorbidities like diabetes, asthma, obesity, they may be at enhanced risk. My experience, and certainly that which I have read both in newspaper and published peer-reviewed literature, suggests that Latina and African-American women are affected disproportionately. Next slide. So fortunately, there's no evidence that there's transmission to the fetus causing birth defects the way we had with Zika several years ago. There probably is an increased risk in preterm births in people that are severely affected. There's no risk to the baby during delivery. So it's not like HIV in the early days when I was at UCLA, where we had to do C-sections for all of those patients. There's no evidence that there's transmission through breast milk. So we encourage moms to pump their breast milk if they're COVID positive and give that to the baby. There is evidence that infants can contract coronavirus due to close contact with affected mothers, but you can prevent that by isolation, which is certainly not desirable, but it is doable. Next slide. So right now, it has made for a different experience for pregnant women. So it's pregnancy is a little bit different than other surgeries in a hospital. It's only, a C-section is the only surgery where you can like bring your husband to. You don't bring your husband to your appendectomy. This has been a big change for our expectant mothers. They're not allowed to have support persons at their outpatient OB visits. They can't bring the grandmas, this type of thing. So visits are kept to an absolute minimum. And this has made it hard in my field where maybe I have a patient who's 45 years old and IVF and she's a diabetic and we were monitoring the baby twice a week because of risk for stillbirth, but we're balancing that with trying not to bring her into the hospital because of the risk of corona. So I think all of you guys could probably speak to how we're not seeing patients as often, and it makes it really sometimes a hard decision in terms of the risk-benefit ratio. At this point, unlike what you may have heard about in New York during the really bad days where partners could not accompany women for deliveries, we do allow that. And even if the partner, I'm sorry, even if the patient is positive, we're allowing the partner to be there if they wear masks. If the patient tests positive, we are encouraging isolation from the infant based on CDC and American Academy of Pediatric data or recommendations, but we can't force it. So the mother can still choose to be with the child. Next slide. So just one last thing to pick up is that every woman does have a right to make a medically informed decision about where to have the delivery. Something that we are experiencing in our field is that a lot of women are choosing to have a home birth because of two reasons. One, they're worried about coming into the hospital and getting COVID or having their child contract it. And then two, we have all these rules. Like if the husband comes in, he can't come and go. You can't bring your own children. You can't bring your mother. And so between those two, there's been a big uptick, at least in my state, where we have like lay midwives and things like that, where patients are choosing a home birth. But we are trying to let patients know that there's still, the safest place to have a hospital remains, the safest place to have your baby remains the hospital. So we're all kind of hearing some horror stories about this, but I understand it from the women's point of view because they've lost so much in terms of their experience with COVID. Anyway, I don't want to make a huge deal about me. I'm not intubating people. I'm not in the ICU, but I also want to make the point that this disease kind of affects all aspects of medicine. And thank you for including me in the panel.
Super, thank you, Sara. And last but certainly not least, Kari Rosenkranz.
So hi, I'll try to be brief because I think people have a lot of questions and there obviously are a lot of stories amongst the panelists about what they've been through. Again, I echo everyone. Thanks to Duncan and to Jamie Gordon for inviting all of us to do it. And I think it's a really interesting topic just for classmates. Obviously, most of us have talked about nothing but COVID for 3 months. So it's nice to get some information. Picking up where Sara left off, I think we all have had a different experience. And when I was asked to be on the panel, my reaction was, I'm a fraud. Because I'm at Dartmouth, so we're in New Hampshire, which is a socially isolated area to start. And while we had a surge plan that planned our 40 ICU beds to bump up to 155, we've actually never had more than 8 filled through the entire crisis so far, I'll say. So my role in COVID has been twofold. One is I serve as the medical director of our breast program. So what's been interesting is to see how non-COVID patients are still impacted by COVID. And there's been expression in our hospital, which I assume we've all used, which is non-COVID, COVID-related deaths, because so many other patients are being impacted either by their disinterest in seeking medical attention or because it is so difficult, as I think Mindy had mentioned, just donning and doffing, taking off and putting on the PPE is so time-consuming that it's difficult to take care of patients even when they don't have the COVID. So in terms of my job doing breast surgery, what's been interesting is to see how quickly people can respond in crisis. And what we've had to do, as everyone in the country has done, is taken what's a normal clinical algorithm and just flipped it on its head. So patients who were scheduled for surgery, all of our OR shut down literally over one weekend, and we had to call people with cancer and say, I know it feels like an emergency, but this really isn't urgent. We're gonna treat you differently than we normally would. And this was happening across all different types of cancers and all different types of diseases. The other, Rafi, my dogs haven't barked all night. until just now. So I'm sorry, as soon as I unmute. The other sort of hat that I wear at work is in medical education, and that's been another area that's been a huge challenge. Some of you might have kids who are already in med school, obviously those of you struggling with kids in college, but pulling people out of traditional educational paths and literally overnight revamping how we educate. With our medical students, we've managed to go largely to a virtual curriculum, but what we had to do with our residents, who are our doctors in training, was put together teams for redeployment. So you all heard Evan's a plastic surgeon who was functioning as an intensive care doctor and emergency room doctor. Our residents kind of again overnight had to train in case they were called to become hospitalists, emergency room doctors. And that was a big part of my response was sort of how to coordinate people and using their best skill set to the best of their ability in a job that is completely unfamiliar and for which they were completely untrained. So that was a really interesting process. Again, we largely, it's okay guys, we largely didn't have to, I'm sorry, to implement any of the action plans that we had in place, but it's definitely an interesting process in terms of just how much creative thinking has come out of this crisis in every industry, but obviously talking about healthcare tonight.
Super. Super. Okay, thank you all. It's great to hear your stories, and the questions have been rolling in, so I'll try to be a good curator of them. I'm going to start with a question that came from Ann Bolton and is related to some questions that came from others too, including the news of the day. So the question is, as you look ahead to summer and fall, how are you feeling about treatment options, vaccine, and the chances for a resurgence, especially coinciding with the flu season?
Rafe?
Okay, I'll jump in first. So let's start with the first question, resurgence. I think that's one of all of our biggest concerns. I think a lot of areas have already seen the local peak of cases and deaths, and resource utilization is going down, and that's really reassuring. I think the data from China, South Korea, and some parts of Europe is now making us concerned about the next wave and what it's going to look like. Honestly, anyone who tells you they know what's going to happen is probably wrong. There are lots of models out there, and in medicine, we like to say all models are wrong, some are useful. Because you can make a model say anything you want. Models are entirely dependent on what you put into them. That being said, and I don't mean to be glib, our experience in the past doesn't really prepare us for this. The 1918 Spanish flu, as it was called, pandemic that had a second wave in the fall that was worse than the first, is an entirely different virus. It has much greater ability to mutate and antigenically shift, and that's probably what caused that second wave. What the inevitable, probably second wave of COVID-19 is going to look like as we reduce social distancing, I don't think anybody knows. Nobody knows if having gotten it once is going to be protective. No one knows what the antibody test means in terms of protective ability moving forward. We're definitely not at the point of saying it's a passport to going about your business and not worrying about it. And we're trying to understand the correlates of protective immunity so you can design a vaccine right now. And we're here already, Kari. Kari asked me earlier asked us all what we thought about new data that was presented today. It was press release, again, not peer reviewed, from the company that's probably furthest along in the United States in vaccine development. It's an RNA vaccine, it's phase 1 study, 3 different doses, lower 2 doses. They took antibody generated by the vaccine from 8 people, and in a test tube, it appears to inactivate the virus. Very exciting, very encouraging. The small vaccine studies seem to be safe. Is this going to be our answer? To be determined. Large studies are going to follow that will be required to answer this question. Therapeutics, lots of stuff in development. Right now, the only thing with even a signal is this drug called remdesivir. To me, it's exciting that there's something with activity, but it's not going to save us all. It's a little bit like the activity of Tamiflu for influenza. It shortens the duration of illness by a couple of days, did not have a statistically significant change in mortality. I think the data has not been yet presented in a peer-reviewed context to really know who is going to most benefit from this. And I say that just because I think something that's not as widely appreciated by people who aren't in medicine is the disease really has almost 3 different phases that are completely independent, right? There's a first infectious phase where you get either an upper respiratory infection or perhaps gastrointestinal or neurologic symptoms. And then some subset of people, we don't know who, progress to lower respiratory tract or pneumonia disease, which can of course be quite severe. But then there's an inflammatory response that takes over and has a life of its own, independent of viral activity on its own. And it's that sort of volcanic or exuberant inflammatory response that is the most terrible and has the most devastating consequences. So it depends what stage of disease you're in if you would expect a treatment to have activity. So when you say X medicine doesn't work for COVID, you sort of have to know, are we talking about very early disease? Are we talking about the pneumonia phase of the disease? Are we talking about the inflammatory phase of the disease? Because you wouldn't expect something with antiviral activity to have activity later. You wouldn't expect something with anti-inflammatory activity necessarily to have activity earlier. So a lot that is unknown. And again, crystal ball is cloudy, what's going to happen. But a lot of work is going on right now, and stay tuned for more information. And I'm sure others have a lot of additional experience to add, so I'll shut up.
So I thought that was great, Rafe. I will tell you guys I'll share my experience at Montefiore when I was back from being sick and in the ICU. We had, a dozen different clinical trials going on in that ICU. And so there was remdesivir, there was convalescent plasma, there was hydroxychloroquine and azithromycin. There were patients on ECMO, which is sort of advanced bypass. And one of the challenges that that struck me, the only thing I can compare it to is sort of in the early days of HIV, where we just had, as a profession, had no sort of idea, not like which antibiotic or but we didn't even know what the beast was that we were fighting. And it felt sort of like that, except that with HIV in the early 80s and into the 90s, it wasn't a, 48-hour, 96-hour evolution. It was like someone got sick and months later they developed AIDS and then died, right? And you sort of watch this happen in a protracted way. With COVID, we were seeing from the time I was in the ER the last week in March, and I was in the ICU the 3rd or 4th week in April. And in that 4-week period, we went from people lined up in the parking lot of our ER to get tested and swabbed with fever and cough and diarrhea and all these different symptoms that we were trying to put together, terrible chest x-rays, to people who were on vents in the ICU. And our ICU census eventually reached something like 600 or 700, which is, like a full hospital or multiple hospitals in many cases, just of COVID patients. And we had no idea what we were treating, right? And so we were trying to put out fires, but didn't know the mechanisms and didn't know what to expect. And so all these, we're starting from zero, or not zero, maybe close to zero, and finding a treatment and a cure and a vaccine for this virus. I think it's going to be a slog, I think.
What I would say, and I don't want to twist this into an inappropriately optimistic moment, because we still have a long road ahead, I think, and we're all aware that we're living in a new world that will probably never fully revert. But I think the one thing from a healthcare perspective that's a little bit heartening is, even though, as was just said, we still don't know how to take care of these people. Someone on the chat box had asked about healthcare workers getting sick, and I think our access to PPE across the country is infinitely better than it was 2 and 3 years ago. Our infrastructure in terms of having the capability of taking care of more ventilated patients, things like that, is much better than it was 2-3 months ago. And I think there's no doubt that the curve is flattening. So the surge that was seen in New York and Detroit and New Orleans, I think is unlikely to happen again because we know how quickly we can shut it down. So on a somewhat positive note, again, without being falsely optimistic, we're definitely in better shape for when the next surge comes. I think we all have to assume it's coming though.
I would like to say just one, since it's a Princeton event, one of the things that touched me most deeply and is a testament to the people on this WebEx, on this Zoom conference, is the Princeton community. And when I went back to the hospital, you know, I guess it all depends on how you want to define adequate PPE, but there were a lot of people who did not have good PPE, even though you might, I guess some people might call it adequate. And I didn't reach out to my close friends from Princeton. They reached out to me and said, hey, what can we do? And people like Ed Hopkins and Andrew Madden and David Gaines and younger guys, Matt Baller from the lacrosse team, and Chad Muir in Texas, and people from all around the country. And I said, you know, we really need PPE. And I didn't prepare slides, but I have a great picture that I can send around of the hallway to my apartment, crammed from floor to ceiling with boxes of Tyvek suits that people from Princeton sent. And it was like, you know, it was like Christmas, I guess, where every day I would show up at the hospital with 200 Tyvek suits and literally go to a unit that didn't have, I mean, they were wearing Yankee Stadium rain ponchos in one unit. Now, I guess you could call that PPE, but I'd much rather have a Tyvek suit than a Yankee pinstripe rain poncho. So that's Princeton right there. And it meant a lot to the nurses and doctors who were supplied, and it meant a tremendous amount to me.
That's a great story. Let me ask a question, clarifying question that's a couple people have submitted. Thank you, Jen Rottenberg and Michelle Marinan. Is the general consensus that we are dealing with a virus, or is it changing enough that having experienced, you know, and developed antibodies for a virus, it's not necessarily protective against something else that's related?
I think we might nominate Rafi again.
I don't want to be
the ID guy.
I don't want to be the spokesperson for all of immunology, but the understanding is, you know, based on experience from SARS and MERS, which is our best analogy, the reason people are concerned is because, particularly with SARS, start to wane somewhere in the 2 to 4 week period after someone gets better. So, you know, with other infectious diseases, you can still maintain immunity when your antibody levels go down. It all depends what the pieces of the immune system that are important in protection are. Sometimes it's not all antibodies. For example, many of us got vaccinated against hepatitis B. We had antibodies. Over time, those antibodies fade. We like to revaccinate people, give them boosters, but there's actually not a lot of evidence that you're not still immune, even though your antibodies have waned. We do it because it makes us feel better. But with this virus in particular, there's concern that immunity may wane. Why? There are these anecdotal reports out of Asia that people who were PCR positive, which is the common diagnostic test we use to make the COVID diagnosis, usually from a nasopharyngeal swab, which means Q-tip up your nose. You can also do it on other swabs. Also, you can do it on a sputum specimen. There are now saliva specimens that you can use to make this diagnosis. Most common one is this nasopharyngeal thing, that people were positive and then they turned negative and then they turned positive again later. And so the question was, were they reinfected? Did they relapse? Or was that negative test in the middle actually a laboratory failure and they really were positive the whole time? And unfortunately, no one knows the answer to that. But it's those anecdotal reports, which are sort of increasing in number, that give people anxiety that either immunity may fade or or that people can relapse or get reinfected. And we just don't know at this point. And, you know, the science is trying to answer this question. It's one of the most pressing questions relative to being able to return to any sense of normalcy, and also generate a vaccine. Because if you don't know what you're trying to create, it's very hard to actively go out and try and do it. So we just don't know. I think that was the question. Jen, did I answer your question?
I think you did. Does anyone else want to add to that? Okay, I'd love to get Sara and Mindy involved a little as well. So let me ask you guys a little bit about, to describe the dynamic that you've experienced at your medical center. I mean, especially Mindy, with what you experienced with the field hospital. How did decisions get made? What kinds of differences of opinion existed, and what was the kind of command structure with all these unknowns for resolving it and moving on?
So I think understanding that we all had a role to play and to try to mark out our lane and then just meet constantly. Like, we just lived at the convention center. I'm home now, which is cool, but it was very fascinating as somebody who's been used to kind of the glacial pace that things sometimes move through committee. That, you know, as we've all seen, that is not how this went down at all. So in our case, the government said, we're not going to micromanage how you do this. We just want you to do it. Just do it. We'll provide the money. We'll provide the PPE, which was key, because we really did want to, we had lots and lots of people that wanted to help and take care of patients, social workers, nurses, docs, but our commitment to them was to have the PPE. And then everybody just built it. It was like the world's fastest game of D&D. Maybe that's part of my Princeton experience that helped with this. We just mocked it out. We're like, let's try this, let's try that, let's build it, let's pivot. But I think getting leadership commitment from two big medical centers and getting some of us into that convention center literally as the FEMA crates arrived, and then just trying to get something up and running. And then as patients came in, and we haven't had huge numbers, which is wonderful, but to try to figure out what types of patients are going to do well in our setting, and to understand that a lot of the patients that are affected by this, they live in really, you know, crowded places. They don't, like, the safety net for them is always thin. And this is, even for the folks that are physically recovering, this is a huge hurdle and a challenge for them, and it's devastating. So again, trying to figure out what we need to be able to be a safety valve for the hospitals and to just build it quickly. It doesn't have to be perfect. It just needs to be there and responsive. So I think that's what I've learned so far.
Sara, did you want to add anything about the dynamic at your organization?
In general, I think they've handled things really well, but obstetrics is kind of like the redheaded stepchild of any hospital. People don't quite know how to deal with it. It's so different than everything else. And as I mentioned, our patients are young females, so they weren't really thought to be at particular risk. So the issue was really a bit more the risk to us. And what we were learning was not that, I mean, I had an 18-year-old in the ICU who was 27 weeks pregnant on Friday. So I don't want to act like there's no risk to pregnant patients, but it's not the typical. The concern is that during labor, women aerosolize. So just as if you were intubating them or you know, doing some of these procedures that an anesthesiologist might have to do. So we really had to advocate in the beginning to get testing and PPE for our unit, because we were not seen as a priority the way the ER or the ICU was. And so we really benefited from the fact that particularly at Columbia Presbyterian in New York, they published their data, and then we were at that point able to present that to the authorities and then get what we needed. But it was more about our risk. And for example, I just learned today that the chair of our department tested positive, and people wouldn't think that with the OBGYN. Yeah, so.
On a related question, and obviously you guys can decline to answer if you prefer. You know, Evan volunteered that he had gotten COVID. If you'd like to share, have you gotten sick? Have you gotten COVID? Or has anyone in your family gotten COVID? And what did you do? How did you protect your, whether you've gotten it or not, how do you protect yourself and your loved ones while you're in the midst of dealing with patients all day?
So I'll answer that in a slightly different way than was phrased. But so I personally have not tested positive for COVID. I have not tested for COVID. I think all of us in healthcare, and probably lots of people not in healthcare, you wonder all the time. And Evan had alluded to the psychosomatic symptoms. So you do wonder, but I think particularly in education, one of the things that a lot of people worry about when you're in a leadership position is when you're kind of throwing troops into battle without the weaponry that they need. So I think one of the biggest stressors was we had a lot of our trainees coming to us saying, what do I do about my family? So it's sort of, Evan had sent his family down to Long Island. I was in a fortunate position where the dogs, with the exception of one in Belgium, have not been impacted. But it was a huge stressor for people on the front lines, was not so much about them getting sick, because I think a lot of people in healthcare, as we've heard, had the put me in coach mentality. How can I help? What can I do? But the fear of bringing it home to their families was real. And I think what a lot of systems did, we saw it in New York, we actually saw it in my local area, even though we never got the cases, is local hotels became essentially hostels for healthcare workers who didn't feel comfortable going home, particularly if they had at-risk loved ones in the home, the elderly, immunosuppressed husbands, wives, children, things like that. And it was, I think for a lot of providers, one of the biggest stressors of this whole crisis was not themselves getting sick, but passing it along.
Yeah, I think, I think that Kari's exactly right. I mean, there's a lot of pressure. We know the little we do know about this disease, we know it's really contagious, and there's a long asymptomatic period, right? So if you get the flu, no one gets the flu and is like, I think I'm fine. And then it turns out you've had the flu, right? If you get the flu, that day that you have the flu, you remember when you start to feel terrible, and that's it, right? You have the flu, you go to bed. The morning I got tested for COVID, I really didn't feel well, but I think under other circumstances, I probably would have gone to work and I would have, tried to muddle through for a couple of days. And that's sort of scary, right? Because, for all of us, and Rafe, you were talking about data and numbers, and it's really, really important, for those of us in medicine, for those of us not in medicine, you have to go back to the numbers, and you have to trust the numbers and the data. And so when I was sick and I was home by myself, it was scary because I had never been sick and alone for 13 days, right? And it's a long time to be by yourself, right? And so that was challenging. And the people in the hospital, who whether they're, old and sick or not, who are dying alone, is really one of the tragedies of this epidemic. It's one of the saddest things I've seen in medicine. Just seeing people die by themselves without a loved one there. I think it's really profoundly sad. But, for those of, most of the people on this call, I think, all class of 92ers, you have to trust the data, right? And so, Katie, you wrote a question, what do you tell your families about what they should do or shouldn't do about protecting themselves? And then, Kate, you had a question about Kawasaki disease. In New York, I don't know, I think there are like 30 million people in the state of New York, and let's say 25% of them are COVID positive, and 25% of that number are kids, and 70 have developed this post-viral syndrome. It's really not very common, and there's been one death. So we get no one misses when a child dies, right? No one misses that story. Old people can die by the truckload in nursing homes, and we sort of don't pay much attention, but with kids, that's obviously not the case. And so I think right now the Kawasaki thing, I don't think it's that big a story. I'm not doing anything different with my 5 and 9-year-old than I would. I hope school opens in the fall. With regard to what I'm telling my family, I have two parents. My parents are 80 and 81, And I'm telling them to stay home. You know, like I think for old people, this is no joke. And but for us and for our kids, you know, you gotta focus on the numbers, not what you're hearing in the news stories. And most of us will get better, and most of our kids will get better.
In that vein, there are a number of questions that are all on all of our minds about reopening schools and universities. So what are people's thoughts about especially given, you know, what Evan just said about the low mortality profile for younger people and the relatively low mortality profile even for middle-aged people? What are people's thoughts about the wisdom and the mechanism and the timing for reopening schools and colleges?
Can I address this as a mother of a college freshman? I think it's a lot more than the health of your child that you need to worry about. It's the environmental services at that facility. It's the professors themselves that are older. So I have a daughter at Yale. They have a medical school. And so that's what they've been kind of messaging to us, is they're worried about, you know, thousands of kids coming in from all over the world with all different experiences. And it's not necessarily just the health of our students, it's the health of the whole Yale community that they're worried about. And so it makes me worried that we're probably not opening. I mean, it seems unrealistic. So my 2 cents.
Sarah, what do you think, what types of mechanisms would you advise universities and schools and so on, governments to use to decide when it is safe to open, and what adaptations should be made to make it safe?
So I'm no way an expert on that, but while we were chit-chatting before the webinar started, I was sharing with the other panelists about a friend of mine's son is going to the University of Miami in the fall, and their president apparently used to be president of the WHO, and he has already said that they are opening. They have the ability to do testing like every 2 weeks. They have some sort of special dorm if kids test positive, and I do not know all of the points, and it might be something to look at, but that seemed to be a place that had a really strong plan, but I don't want to profess to be an expert on this. It's really complicated.
Yeah, Sarah, I mean, I think that's fascinating, and you know, maybe I don't know if it's possible to get a hold of that plan and share it with people on this webinar. I think people would be very curious to know at least what some institutions are doing, because you know, my concern is I don't proclaim to have the right answer or even any answer, but you know, I think all of our concerns is, right, you know, somewhere between 25 and 50% of people who get COVID are completely asymptomatic and they're shedding. And then another portion are the most infectious when they're going to become symptomatic, the 48 hours before they themselves have any symptoms. So how does testing, you know, on some sort of regular interval, how's that going to interrupt the cycle? It just makes me anxious. I'm not saying we shouldn't do it or we shouldn't try it. I just have this fear that we're going to try it. There's going to be an enormous resurgence in cases, and we're going to be back here again. And I fear, I hope I'm wrong, but I fear we're going to be there until we have a vaccine. And you know, I hope I'm wrong about that.
I think you're very conservative and true. I mean, there's a lot that can happen between a test and 2 weeks later. So.
I think one take home, I'm sorry, Duncan.
No, please go.
Oh, no, I was just going to say one take home, and this is not to bring politics into this discussion, which I think is going very pleasantly apolitical. But
oh, don't worry, we're going there.
Sorry, let me preempt all of this. We already covered the vaccine thing. But what I was going to say is just hearing the disparate opinions amongst people who are really bright experts. I think everyone who's listening should realize these are not easy questions. And I think it was Rafi who said it in the beginning. The truth is nobody knows. Nobody in the world knows. Nobody can predict what's going to happen next. And I think, you know, we're clearly seeing that play out in this country every day now.
You know, you mentioned our country's experience, and of course, we've also had the chance to observe some experiments that are going on in other countries. So Jeff asked, how would you guys grade the American public health system in its response and management of the pandemic as compared to other countries? And I guess we might be entering the political portion of the evening.
Didn't mean to steal your thunder. Sorry, Duncan.
Well,
Also America's response versus other countries.
I mean, everyone's different, right? And so I don't know. I mean, I think what we saw in Wuhan and South Korea with the forced isolation for family units with a positive test was effective, right? And if you can pull that off socially and politically, that's a good way of reducing the spread of the virus. I think in New York City, I spoke to a friend in Colorado recently, and she said, I can't believe our economy shut down and we're not at work. We don't really have a lot of COVID here. It just seems like an inner city disease, which is sort of interesting, right? And I said, look, the virus, people say like it's like the flu, right? In terms of numbers, and we're weighing shutting down the economy against flu-like numbers, but flu-like numbers in 6 weeks with the economy shut down we don't see that with influenza very often. And so I think we did the right thing, maybe late. The supply chain things, I sort of give the government a little bit of a pass on because I don't know that anyone really saw it coming the way it hit New York and some other hotspots like New Orleans and Detroit. I think the hospitals and the hospital leadership is sort of an interesting field. Most hospital leaders are either doctors who become businessmen or businessmen who pretend to be doctors. Neither is a great match, I think. And I think big hospital systems were thrown into a challenge that they never even, drew up on a white paper in their weekend leadership course. So I don't think they did a great job, but I don't know really who did. I don't know that there's an example of a super great public health response out there.
Australia, maybe? I mean, they closed all their borders. They have an app where they track people, and it doesn't save privacy data, but it lets you know if you were close to someone with COVID. I don't know if anyone's followed Australia, but they seem to be doing a pretty good. They're an island too, and they're educated, and there's less, not heavily populated, et cetera.
Yeah, but it's like New Hampshire, right? So like you can do anything if people are spread out and basically healthy and they're not on top of one another. Like I'm sure, and again, Israel sort of had good contact tracing. I know the Bronx pretty well. I haven't seen or heard of a response that could have done a whole lot better in the Bronx. I just think it was a cauldron.
I think we do know what works. And unfortunately, it's antithetical to a lot of our cultural norms, right? You have to test as much as you can. You have to isolate and quarantine, and you have to have people who are willing to essentially do things that are really virtually intolerable for the good of public health. And we're a country based on freedom, and we've never had to do anything like this. It makes it very hard to start with. I think if you look at the countries who have been more successful, they've been countries that don't have the traditions of freedom that we have enjoyed in this country. So it was sort of a setup for a really challenging situation to start with. I'll wait in there. Marjorie said we get a D. I'll say we got an F. So have at it.
So my little bit, the CDC went from saying N95 single use to, oh, you can use it for a long time, to somewhere in there bandanas were okay. Like, I mean, the word bandana and a CDC guideline, that doesn't feel right.
Has anyone followed the experiment in Sweden, and what are your thoughts on their bid to acquire herd immunity by not having as much social distancing? Do you consider, how do you think that'll end?
So one thing, in just thinking about, I think, people are going to study different countries' initial response to the outbreak for the next 100 years, and way smarter people than me are going to grade us and weigh in. I'm very interested to see what is our country's healthcare system going to do in the next 12 months to 10 years. How are we going to, the initial shock and impact of this disease is one thing, and we're wrestling with it, but we can all in different ways see how this is going to unfold from a health perspective, whether it's continued waves of COVID or all of the patients with all of the comorbidities that, again, somebody brought up early in the call about how we all started our careers at the beginning of the HIV epidemic. And while this is different in some respects, there are some parallel things forever. We all remember when, sharps care, when we took care of patients, we had to all be taught, don't just put the sharps wherever you feel like it. Now, you don't even have to teach people that. They know that. So this is going to change some things about healthcare. I'd like to see, just like there were some downsides about American culture and how we responded to the initial wave, there's some strengths there too and some resilience. I would like to think we've got people working on health policy and what this is going to do to hopefully make it better, different. But how are we going to continue to ride this out?
So Evan, you told a great story about how people helped answer the call, literally and figuratively, in the early days. Now that things have flattened out, literally and figuratively, a little bit more, what could non-medical professionals best do to help right now? And answer carefully, because you may fill up your hallway with whatever you ask for.
Yeah, it's not PPE, right? It's sort of the intellectual and creative power of our classmates and community to look into the future, and it's not going to be a sort of step change. It's got to be a sea change. Where our classmates can help is I don't know, unless someone has a great vaccine in their freezer. I think we have to there are a lot of problems with healthcare in this country, obviously, and wherever you live, if you live in Texas or New York or Alabama or New Hampshire or wherever, there are a lot of problems with the way we deliver, pay for, value, et cetera, healthcare. I think that's where the resources have to go. It just needs to be taken apart and put back together again. And I don't know whether this is going to be the spark that lights that fire, but it certainly has exposed a lot of our problems, and I think that's what we need.
What sticks out for you most as an example of those problems?
So there's that video that I'm sure many of you have seen of Bill Gates giving a TED Talk 5 years ago about sort of predicting exactly this pandemic. And I think about, I went down to Haiti during the earthquake, and I was part of this group that went down from our hospital, and everyone was sort of in the same boat, setting up little mobile hospitals. And then the Israelis came and in 45 minutes set up a fully functional OR, CAT scanner, triage, et cetera, et cetera, et cetera. And you could just tell that there were people who've thought about a solution to a problem and have worked it out. And then there were people who are sort of trying to figure it out on the fly. And I've just been through an experience at my hospital where we had to figure everything out on the fly, and it was painful. And if you're in the PR department, you celebrate that and say, hey, we're so nimble and we're so creative and we're so resilient. if you were looking at it from outside, you'd be like, you guys are terrible. You're idiots. Like, why didn't you have a plan for this? Why couldn't anyone see anything like this coming? And, you know, and I think we have to focus on that. And you know, from PPE to the way we move patients around to the way we contact trace, everything, Duncan. I think everything. You know,
Great answer.
I'm seeing a couple of comments from Marjorie and Matt about kind of healthcare disparities. And I don't know if that's something we've really talked about, but the people I'm taking care of, I have yet to take care of a Caucasian COVID patient. I'm sure they exist in other places, but they are Latina and African American. And, you know, and then I live in this beautiful village of Chevy Chase, where all my friends are worried, and some of them are upset because, you know, the Wi-Fi is not working in their country house, so they have to be home because the kids are doing online learning, and they're all getting Instacart from Whole Foods. And who's taking those, you know, making those trips to do the Instacart? It's people that are like my patients. And I feel really troubled by it. And you know, I see this comment about Singapore, but they're having all these problems with their migrant workers who are sick. I think I've actually read that about Sweden, that their Somalian population is really hit. Is anyone else experiencing that? Because I just, where I'm giving my charity money right now is food banks locally, and then to Doctors Without Borders, because as bad as this may be in our country, it's going to be so much worse in the world.
Yeah, our experience, you know, no shortage of healthcare disparities in the Bronx. You know, our experience and looking, I just was looking at our data, hospital-wide data, with a colleague of mine the other day, was less socioeconomic and less racially segregated than health. So, you know, fat, wealthy, white guys who are old from Westchester did as poorly as fat, poor, you know, Latinos from the Bronx. And the common feature wasn't where you lived or what zip code or household income, but it was like, you know, if you're fat and old and diabetic, you're in a lot of trouble with COVID. And so, you know, I think the things that co-segregate with socioeconomic disparities, like closer living quarters or delay in seeking medical treatment or those other things, yeah, definitely play a factor. But, you know, and your early question about our parents, I mean, the reason I'm keeping my parents sequestered is if you're 80 and you get this, you're in a bad way.
So moving to talk a little bit about kind of the longer term planning that Evan, you and others have alluded to. If each of you were respectively either king or queen for a day, what's the #1 kind of policy response or policy change or infrastructure change that you would advocate for to better prepare ourselves the next time a scenario like this comes around? Remember, you got a whole day, king or queen for a day. You can do whatever you want. So don't hold back. Don't waste your day.
There was an article in The Economist this week that asked, or some paper, I guess, but that asked whether COVID will prove or test or disprove globalization or globalism. And, you know, there are smart people, some of whom are on this call, who, you know, could have predicted that there's no reason why the virus should not have come from, you know, Wuhan to Japan to Singapore to South Korea to Washington State, or from Bergamo to New York, right? That's going to happen. And so I guess what I would do if I could go back in time and move resources around was I would have had a coordinated global response, right? And you know, not to politicize it, I guess, but like, you know, when people lash out at the CDC or the WHO or the U.S. government or any big group, it just would have been, I guess if I could do things with a snap of my fingers, this was foreseeable, right? I mean, there's no reason why it should have stopped at the border of Wuhan. And we were just totally unprepared. As Bergamo, as they were dragging bodies to makeshift morgues in Bergamo, we were like, yeah, well, there are only 11 cases in New Rochelle. Right? I mean,
it sounds like you're saying that we were unprepared as a global community, not just within the U.S.
Yeah, I think that's true.
And I think just following up what Evan said, one thing we've seen literally around the world, and I think we kind of keep saying, let's keep it relatively apolitical. I think it's hard to, because what we've learned at every level, and actually Evan and I were talking before this call, one thing we've learned even at institutional levels is the importance of leadership, of leaders who are consistent, transparent, communicate well. Communication is so critical. Listen to expertise. And certainly in my institution alone, we saw some great examples of great leadership, people leading from the front. Nobody had great data going into all of this, right? We could look to Italy, we could look to China, but nobody had an experience that we could say, let's just do it like they did because it worked. So I think people outside leaderships understood that mistakes would be made. I mean, I think all of us in healthcare were working in institutions where policies were changing sometimes 2 and 3 times a day. And I think people can bear with uncertainty as long as they're given the information to the best of people's capability, as long as there's some consistency, some sense of foresight and planning as best as possible. So choosing leaders at every level, I think, is something critical for all of us moving forward, because it's already been said, this has been predicted for a long time. Letting go of our stockpiles, taking money away from the CDC, all of those things set us up to fail from the beginning.
Does anyone have a thought about us dropping out of the WHO? And I mean, anyone who knows anything more than I do about where this is, like, anybody?
I guess the one thing I would say is I just want to plug, in addition to everything that Kari and Evan were saying, is I think public health and public health preparedness on a national level and globally is underappreciated and under-resourced. And, you know, I mean, no one likes, you know, Chicken Little, the sky is falling, people who claim doomsday is around the corner. But this has been predicted for a long time that this was inevitable. And we were sort of caught with our pants down, as was the global community, in terms of readiness. And one would hope that one of the things that will come out of this will be a new appreciation for epidemic preparedness and planning. And I think that has to be something that's longitudinal and cross-administration going forward, because this is evidence of what happens when the system, it does not have coordinated leadership, as others were saying. And I think that comes from the WHO on down to each individual country's response.
Mindy, did you want to add anything to the magic wand question?
Well, what I'd like to see, like, for example, I was part of a tiny little telemedicine project that we tried to get going for like years. And, you know, nobody could figure out if it was going to make money because payers don't reimburse for it. This is like, you know, pre-pandemic. And suddenly, you know, when we needed telemedicine, it's now a thing, a big thing. And that's not going to go away. So I think this is sort of like when your house burns down and you're going to rebuild. You're not going to rebuild and put the back door where you always hated it. You're going to build the house better, hopefully different. It depends on the budget. So I think, again, smarter people than me will look at the economics, health policy, and say, what do we keep? What do we get rid of that wasn't working? How do we align? In our country, you know, we don't, and again, I don't want to get too political, but our current system is such a hodgepodge. We can't figure out what all the different payers cover on a normal day. I think we have an opportunity to come up with something better, that'll be better for the public health, and that, you know, we'll still take into account some of like all the different economic drivers. So that's what I'd like to see come out of this.
Thanks, all of you. Kari, you made an interesting point earlier about some of the kind of collateral damage around COVID that isn't necessarily literally COVID disease. And Janine asked an interesting question about mental health, especially with regard to, you know, children and teens who are being quarantined or you know, unable to go to school. Some of them, you know, many don't have internet access, and therefore they're not able to learn at all. There could be some substantial mental health repercussions for them. So do any of you have any comments on the mental health side of things?
I think Janine made a great point. I think there are lots of people struggling for various reasons, some of them with pre-existing conditions, which obviously have been exacerbated by loneliness, depression, financial stressors. All of those things clearly are worsening people with underlying mental health questions. But I'm certainly not an expert and I'm not a pediatrician, but from what I've read in the lay press, there's no doubt that the teenage population probably will suffer the most for this. And you know, it speaks to what Mindy said. I think a lot of changes in how we deliver healthcare will come from this. We're going to need more mental health providers. I think more value of mental health providers who typically are not covered by insurance plans, never mind the uninsured who can't access mental health care. And I think we all need to advocate for that. You know, again, going back to the question, what can people do? It's advocate in the areas that we know we have underserved populations, whether that's by race, religion, or disease site. And mental health has never been really considered in the same conversation. People die from cancer, but they commit suicide as if it's something they've done to themselves, and it's not. It's a mental health crisis, and we need to reframe the whole conversation around mental health even before COVID. Maybe this will be a great catalyst and something good will come in the mental health care community because of it.
So is there already, do you feel like there's discussion, a direct discussion about the impacts of COVID on mental health? Do you think it's recognized as kind of part of that collateral damage?
It's a great question, Duncan. I would say it's recognized. I don't think it's at all being treated yet.
Evan, your thoughts?
Yeah, I mean, I think that we work very closely with a palliative care team, and they're, you know, on a good day in a place like the Bronx, finding a psychiatrist to treat someone with depression, anxiety, schizophrenia, anything, is so difficult. And now with the repercussions, the sequelae of this, whether you've lost family members. I took care of a woman in our unit whose son and husband had died in the previous 72 hours. She died the next day, and she had another son. And I was thinking, this poor guy lost 3 members of his family in 96 hours. How do you pick up the pieces from that? And I don't think we've scratched the surface of dealing with the mental health issues that are going to arise from this. Not even close. We're still trying to put out fires, you know.
Any other thoughts on that topic? Okay, a couple people have asked a little bit about, 90 days ago, I'm sure none of you could foresee the position that you'd be in and how your work has changed and all that. And how has your Princeton experience prepared you for this moment?
I actually went to Trenton State. I don't know if any of you guys.
I knew it.
Not being there that helped.
I don't know how I got on the panel. I don't know. Oh, I don't know. I mean, I think everyone draws on past experiences and strengths, and during dark times or difficult times, you pull resources from different places. And, certainly for me, and I think for many of you, Princeton is one of those places from which I continue to draw strength. And So in a material way, I got tons of PPE from friends who cared about me and my coworkers who were Princeton people. You know, whenever I have a really difficult problem in surgery, I call Kari and she solves it for me. So that's another area, another way. But, you know, it's nice to have that in our back pockets, I think.
I think what I found in this crisis was it required a lot of creative thinking. And I think Princeton taught us how to think. You know, medicine tends to be a very algorithmic specialty, and all of a sudden we're out of the box. And I think some people really responded well to that. And I would like to think the people on this panel responded well to that. And that's why we're here. And I attribute a lot of that to Princeton and to the community of Princeton and to our peers just in casual conversation in the dorms and the clubs. You know, we were surrounded by people who challenged us intellectually. And I think we really did learn critical thinking in a way that we might not have somewhere else.
I received money to go to Princeton, and I was conscious of the motto, Princeton in the nation's service. And I knew that I wasn't probably anyone that was headed to Wall Street or something like that. I was going to do something that would give back, and I ended up in medicine. And then I chose a position where I would have at least about half of it an underserved population. So I guess I would say that kind of that motto or that idea is something I feel today.
I guess the only thing I would add is I often reflect back on my undergraduate experience and talking to other people about their college experience. And I am just so grateful for the education I had and the opportunities to explore great things. I was a chemistry major, but I took some amazing history classes and some great art history classes and politics classes that had nothing to do with my major. And the broad way that we all challenged each other as we studied, I think set us all up for being involved in this crisis. And just seeing the comments and the questions from people who may or may not be involved in healthcare that are coming in on this chat and in these online Q&As just make me so proud to be a Princetonian and from our class, because these are all incredibly insightful, important questions and activities that everybody outside of medicine is doing to think about and problem solve so we don't find ourselves in this situation again. So I think it's playing out in a lot of multifaceted ways.
I would agree. I think the undergrad training and experience for most of us, we really learned how to read and write and think critically, and how to collaborate with other folks who came from, you know, different experiences. And, you know, medical training is far more hierarchical and rigid. There's room for some creativity, but it's not like that foundation or that community. Just the fact that so many people are coming together for this session. We stay engaged, even for folks that don't go to a lot of reunions. I think this is a moment where it's an opportunity for everyone nationally with any skills of any kind. They don't have to be medical. Everybody needs to work this problem hard and figure out what we rebuild and what we add to it. We need everybody to fix this.
Well, Mindy, you anticipated the final question perfectly there. You know, we talked a little bit about the mental health challenges, and I think it's a challenge for all of us to, how do you help? You see all these things going on. You see the pain and the difficulty. You see the uncertainty. So, what is your advice? Each of your advice to non-medical professionals? You know, or another way to look at it is, if you weren't a doctor, you know, what would you do with your time and money that you feel like would be most impactful to help out? And you can mention specific charities or projects by name, or you know, places to volunteer. I think there's a lot of people that would, you know, that would love to help more and that aren't medical professionals and would love your advice about where that would be most impactful.
Yeah, I don't have a good answer. The best answer I can come up with is, you know, I'm looking at the Venn diagram of solvable, you know, addressable problems, and important problems and trying to find the intersection, right? And if I weren't a doctor and I wanted to do something, and it's going to vary depending on where you are in the country. Obviously, if there's no COVID, then you're going to have to give somewhere where there is, right? But I think the two things that are really important are food banks for the community. A lot of people are out of work, and iPads for communication. Because I think that the two things that I've seen most disrupted are, families, they just don't have food, especially in poor areas of the country. They're out of work, shops are closed, food banks are empty. And, hospitals, I just heard a great story today about a guy who was donating iPads to hospitals so that patients could FaceTime. I think it's really important.
What I would add to that,
access and technology access.
Yeah.
I think what I would add to that is, and I think everyone on this call is on this call because they really care. From a very personal perspective, the masks make a difference. I think you've all heard it. They're not protecting you. They're protecting you from other people from you. And I think we just need to continue to wear the masks until, as we've talked about, there's a cure, there's a vaccine, there's something different. And really socially distancing when we need to. And I imagine that's going to wax and wane for a period of a year or more. And we'll have windows where maybe we can be a little more public and windows where we're going to have to shut it down and people are going to have to be nimble in that way. The other thing I would just add to what Evan said is it's not just the food in the food banks, and I think people know this, it's the family centers. So it's diapers, it's formula, it's things that people who are really struggling can afford. And the other group of people who are really struggling, which is tragic, domestic violence is a crisis right now because people cannot escape their homes. So some of the centers that are working with either abused children or abused partners are critical, I think, to support right now because the isolation, substance use, things like that are worsening and people have nowhere to go. So those are the only things I would add in terms of, as you mentioned, Duncan, if people have the money to give, it's a great place to give.
I would add supporting good journalism, supporting the national debate, we are people that can think critically. Everybody on this session who's sending in all these wonderful questions, we need to help steer our leaders and public policy. We can't just opt out of, say, I'm not going to get on social media because it's a disaster. We have to contribute to help our local governments, our state governments, help the journalists to get the right information to the public and get the moderates, because they're there, to drown out the noise from the fringes.
Rafi, your thoughts?
Yeah, I agree with all of those. The other thing I would just add is if you're feeling a little bit more globally focused, just remember that, the wave is really about to hit the shores in Africa. And they may be a continent that has a lot more experience dealing with pandemics. They dealt with Ebola and all the hemorrhagic fever viruses, but the fragility of the health systems there are dramatically they're so much less robust than anything else we've been talking about, that Doctors Without Borders and the International Red Cross and the groups that do local NGO work in Africa is something to consider also. That's not to say there isn't devastating need that we can address at home. I'm just adding to a really important list that others have already identified.
Super. Well, I think we're going to leave it there. You guys can all see on the chat the flood of appreciation from your classmates. So I just want to add my voice to the throng. And I've always been very, very proud to be a member of the Princeton class of 1992. But if it's possible, I'm even prouder now having heard about the great work that you guys are doing, and also the great participation by some 90 of our classmates and the thoughtful questions that came out. So thank you one and all, and stay tuned for the second part of the panel, which will feature non-medical professionals, and we will post the date. It'll be within the next 2 or 3 weeks. We'll post the date on Facebook, and we'll also send out the recording to this one. So thanks again, everybody. Enjoy your night, and thank you, COVID Heroes, for all that you're doing.
Duncan, thanks for doing this.
Good night.
Great job moderating. It's not easy.
Bye, everybody.